You're dispatched for a 64-year-old male who passed out at a family barbecue. On arrival, he's profoundly pale, diaphoretic, and ill-appearing. He's supine on a backyard patio, responsive to voice, oriented to name and place only, clutching his epigastrium and low chest in a precordial salute. The firefighters who arrived on scene first sheepishly admit they can't hear his blood pressure. Just to be clear, he looks like warmed over death. I'm Angry Bill, and this is another scenario discussion. The earlier ones will be grouped into a playlist you can find on the Prehospital Wisdom channel page. If you missed any of them, make sure and go back and look. The concept is that I hate it when social media asks a good question, shows a good x-ray or an EKG or whatever, and I don't get any answer except wild-ass guesses in the comments. So in this video, I'm going to give you a case. You can pause it if you want to think about it, and I will answer it right away. This scenario de-emphasizes differential diagnosis and instead will present a treatment dilemma. After I lay out the scenario, I'll go over the answer. No need to wait or be disappointed about never getting an answer. Plus, you can tell me right away that I'm wrong down in the comments. So let's run through this situation. As I was saying, you were dispatched for a 64-year-old male who done passed out at a family barbecue. On arrival, he's pale, diaphoretic, and ill-appearing. He's supine on the back patio, responsive to voice, oriented ×2, clutching his epigastrium and low chest. As for symptoms, family reports a brief witness syncope about 10 or 15 seconds, preceded by queasy, lightheadedness, sweatiness. He looked terrible, so he was lowered to the floor without injury when he lost consciousness. He now reports mild pressure-like chest discomfort, 3 on a 10 scale, that's worse with exertion. It's not pleural or palpated changes. Nausea without vomiting is present as well. For history, he's got hypertension, hyperlipidemia, no diabetes. He takes lisinopril and atorvastatin. He did take sildenafil earlier today, just in case. Good for him. No allergies. He's got a heart rate of 37 irregular. You reattempted a blood pressure, got 78 over 46. His respiratory rate's 18 and shallow. His pulse ox is 95% on room air. Skin is cool and clammy. Neck veins are slightly distended, but his lungs are clear to auscultation bilaterally. For neuro, he's got no focal deficits, no seizure activity, no postictal confusion. As for the 12 lead, here you go. Go ahead and pause it real quickly so you can see. This is a complete heart block with narrow QRS. You can see the P waves in the tracing and the PR intervals never repeat themselves, meaning complete AV dissociation. But that's not the important parts. The important findings are the bradycardic heart rate and the inferior ST elevation. Notice the elevation in 2-3 and AVF with depression in AVL. That, my friends, is an inferior STEMI. When you run V4 right, you can see that there's a millimeter ST elevation there as well. Based on all that, what are your treatment priorities? How do you want to go about this? How does the bradycardia, hypotension, and MI affect your decisions? Go ahead and pause it real quick and think about it. What we're really asking in a general sense is, do you want to treat this STEMI, in which case you kind of can't because he's bradycardic and hypotension. So do you treat the bradycardia and hypotension and whip that sick heart? It's kind of a little bit of a treatment dilemma. First off, recognize this is an unstable symptomatic bradycardia with inferior STEMI and right ventricular involvement. The hypotension, altered mentation, or syncope and ischemic chest pain would each arguably make this patient unstable. All of them together, there's no question. Number 2, avoid preload reducing meds like nitroglycerin. Nitroglycerin is contraindicated with hypotension, the elevation in V4 right, and the recent Viagra. I would also minimize or avoid morphine. For me, I'd use fentanyl in tiny titrated doses only if needed and if the blood pressure tolerates. Support preload and perfusion. I'd give an isotonic fluid bolus of 250 to 300 milliliters, reassess the lung sounds and blood pressure, and maybe repeat that cautiously. Remember, the goal MAP, the goal mean arterial pressure, is greater than 65, and a goal systolic blood pressure is like kind of about 90, especially with that right ventricular infarct. MAP, by the way, stands for mean arterial pressure. It should be above 60, but 65 millimeters is even better to perfuse critical organs. You figure it by adding diastolic, and systolic pressures, then dividing by 3. In this case, 46 plus 46 plus 78 is 170, divided by 3 is 57 millimeters of mercury or so. I'm not trying to get dude's blood pressure to 120/80. I need 5 to 10 more points of MAP is all. Treat the bradycardia despite the MI. Do I really want to whip a sick heart? Yes. Not whip it, push it. I need a bit more cardiac output. I need to perfuse the heart itself along with the brain, liver, and so on. In this case, the best option for me would be atropine 1 milligram IV push every 3 to 5 minutes to a total of 3 milligrams. This is a proximal heart block, which I'll explain in just a second. The narrow QRS complexes mean this is a high-level nodal block and atropine is indicated. If atropine is ineffective or the patient remains unstable, I would then initiate transcutaneous pacing immediately. The other reason to jump straight to pacing would be that I couldn't get IV access. Finally, if transcutaneous pacing isn't capturing or poorly tolerated, I would either start an epi infusion or a dopamine infusion. Either of those would be slowly titrated to perfusion and mentation. Regarding STEMI care and destination, I'd give him 324 milligrams of aspirin to chew on if he's got no allergy and not actively bleeding. Oxygen only to maintain a reasonable pulse ox at 94 to kind of 98. ACLS calls for above 90, so you do you. Call an early STEMI alert to a PCI capable center and notify them that they got a complete heart block. Frequent reassessment and repeat the 12 lead after the rate improves. Is that what you would have chosen, or would you have chickened out regarding treating the bradycardia? In this scenario, the patient received a 300 milliliter fluid bolus and atropine 1 milligram IV. The rate rose to the 50s and the blood pressure improved to 98/62. Stop and think about that really quick. What's 62 plus 98 divided by 3? What's his MAP now? His mentation improved, but chest discomfort persisted at that 3 out of 10 scale level. The ST elevations remained in 2, 3, and AVF. Good job. Continue transport with pads on and pacing ready, and call the hospital with an update. Now let's talk a little bit about the pathophysiology in all of this. Why increasing the heart rate comes first, even with MI. The bradycardia is the most immediate threat that I can deal with. The low cardiac output from profound bradycardia and AV dissociation leads to hypotension, syncope, coronary hypoperfusion, and worsening ischemia. In proximal AV nodal suprahis block, suggested by the narrow QRS and the junctional scape, atropine can work because it reduces vagal tone and enhances conduction through the AV node, often improving rate and blood pressure. Inferior MI-related blocks are frequently transient and nodal. Raising the rate with atropine or transcutaneous pacing restores perfusion pressure, improving both systemic and coronary flow. Conversely, doing nothing because it's an MI leaves the patient in shock, and giving nitrates and vasodilators in right ventricular ischemia can collapse preload and worsen hypotension. Why a third-degree block pairs with inferior STEMI and why it's narrow. The AV node and proximal His are usually supplied by the AV nodal artery, which most often arises from the right coronary artery. Inferior STEMI typically reflects right coronary artery occlusion as well in most cases. Ischemia or edema of the AV node produces higher grade or complete AV block. When the block is at the AV node, the ventricles are still activated by a junctional escape conducted normally through the His-Purkinje system, giving a narrow QRS and rates about 30 to 50, 40 to 60, somewhere in there. In contrast, anterior STEMI often injures more distal infra-His conduction system. This results in ventricular escape rhythms, slower, wide complex QRSs that respond poorly to atropine, and more often require pacing. There are a few red flags and pitfalls to be aware of. Critical errors would include giving nitro to this hypotensive right ventricular and recent PDE5 inhibitor use patient. He's on this sildenafil, and so that precludes nitro. That often gives a precipitous and long-term BP drop that can't be turned around. Skipping the right-sided leads, missing the right ventricular involvement, and overusing preload reducers, undertreating pain during transcutaneous pacing leads to agitation, loss of capture, catecholamine surge. Oversedating, on the other hand, could mean apnea and or hypotension. Relying on atropine when the QRS is wide delays pacing. Forgetting repeat EKGs after the rate and BP improve, ischemic patterns can involve. So to review, treat the physiology you see. Unstable bradycardia gets rate support now, even during MI. QRS width guides the therapy. Narrow proximal nodal atropine may work. Wide QRS is distal pace or pressors early. Inferior plus or minus right ventricular STEMI loves preload, hates nitrates. Right-sided EKGs change the management. Prepare for escalation, pads on early, analgesic and sedation plan for transcutaneous pacing, catecholamine infusions ready, and a PCI destination locked in. So what do you think of all that? Let me know if you like this kind of video by liking, sharing, or giving me a quick sub. I really appreciate your support in that way. Thank you. If these scenarios seem to be well received, I'll continue with regular case scenarios. I'm Angry Bill. This is Pre-Hospital Wisdom, and until next time, stay safe.